think everybody's really ready for this session. So it's, people looking forward to it. Great. Thank you so much, everybody, for coming back. I know the conversations and the breaks are really important, but we'll have a good break at lunch again. So we're going to move now into the next session, and I think we're really ready. The previous panel has primed the pump, literally and figuratively, for this session with the Christian health associations. Across Africa and India, these associations are playing, obviously, a critical role in championing the issue of WASH in healthcare facilities through their networks of healthcare providers, helping to drive progress at scale. It's my pleasure now to introduce Krista Peterson, who is the administrator for the Watersheds Foundation, and I'd also like to note is one of the key members of our organising committee, and really it's thanks to her that we're here at all in terms of the actual details and logistics of the support. So Krista, just to acknowledge and to appreciate your role there. The floor is yours.
Thank you, Jean. So as you see, we have again the website up, and we have that commitments document, and all three of these organizations have put in their commitments. And so I urge you to look at those. They'll be up for a while, so be sure to look at them when you have a chance. And I'm going to try multitasking. I have there's three wonderful people up there in the booth who have been helping me immensely. I mean, really doing it all. I shouldn't even say helping me. With all the audio-visual, they are in charge of the live streams. When you speak, they actually zoom a camera in on you, so that the live stream people can see who's speaking. So would you give them a round of applause up there? And I'm going to try to do this from the floor. We had a small issue with the projector during the previous presentation. I apologize for that, but we think it's fixed. So I'm going to have our four panelists today introduce themselves briefly, and they're going to tell the scope of the healthcare facilities they reach. And it is pretty darn impressive, I'll have to tell you. So Nakata, if you would start. Do you want me to introduce myself and talk? No, just introduce.
Thank you. I'm Katha Njero. I work for the Africa Christian Health Associations platform, known as HAP. We are based in Nairobi, Kenya, and we are an organization that convenes Christian health associations, and you'll hear more about those from Peter. And we are present in 32 countries in sub-Saharan Africa, bringing together more than 43 associations, and that is thousands of health facilities, more than 10,000 health facilities on the continent, serving more than half a million people. Thank you.
Good morning, everyone. My name is Ruth Jemmy. I work with the Africa Christian Health Associations platform as a program management advisor. Thank you.
Warm greetings from Accra, Ghana. I'm Peter Yeboah. I'm the Executive Director of the Christian Health Association of Ghana, which is a coming together of 42 Christian denominations in health, owning 375 facilities. And in terms of output, we care for between 8 to 10 million Ghanaians every year. We also own 22 health training institutions, and we produce 5,000 nurses and midwives every year who are redeployed to the entire country. And we are the largest non-state actor in health. Needless to say, we always target the underserved, poorly served, and the neglected segments of the society. That is CHART for you. Thank you.
Namaste, everyone. My name is Ronald Latanoya. I come from the Christian Medical Association of India, which is a network of more than 270 Christian hospitals across India. It is mainly from the Protestant and the Orthodox churches, and we have 5 medical colleges as well. There are more than 12,000 Christian healthcare professionals, that is doctors, nurses, allied health, administrators, and chaplains as members of CMAI. We, along with our sister body, which is the Catholic Health Association of India, we have around 80,000 beds across India, mainly serving the rural and hard-to-reach areas. We have been in existence for 120 years, 1905. We've been doing healing ministry since 1905. Thank you.
We had also hoped to have 2 sister doctors with us from India, one who runs the Sister Doctors Forum of India, and one who runs the Catholic Health Association of India, the first woman to run that organization. They unfortunately, we learned of them late. We actually learned about Dr. Ronald through Nkata, and we got to him in time, but the other 2, we were a little late for getting the visa process. But they also have a huge reach. We're going to maintain contact with them, and they put a report in our wonderful commitments document. So again, please read that. So we're going to start with Nkata, and she'll kind of give the overview of what they do. And then we have a fun little thing with Ruth to do. And then we'll have Peter and then Dr. Ronald. Partly why I had them introduce themselves is I was afraid to say Dr. Ronald's last name. It's long. So I appreciate you doing that. So Nakat, if you want to start.
Yes, thank you very much, Krista. HAP is very honored to be part of this gathering, including being co-convener. And I was smiling through the questions in the last session where everybody was talking about how do we coordinate. And I think that we have part of the answer, not everything, of how to do this, because every one of the things that you're talking about in a mission health facility in sub-Saharan Africa is talking about HAP and the Christian health organizations, associations. And so who or what is a Christian health association? So some of these associations have existed for more than 100 years. And since the missionaries came on the continent, and started mission hospitals. They began in different countries to think of ways of coming together, at least as Christians. Peter might talk about it as well, but I know even in Kenya, because Jacinta and KCCB Health Department is part of HAP, is that we are Christian, but we have ways in the country to work with other faiths. So for example, Kenya has the Kenya Faith-Based Health Consortium, which brings together all other faiths on the technical side. So Christian health, so the mission health hospitals in any country come together under a national umbrella known as a Christian Health Association. In some countries, not because they cannot work together, but because that's the way probably things started when they were formed, we have the Protestants having an association, and then the Conference of Bishops has the Catholic facilities as under a different organization. But in other countries, everybody, for example, in Zambia, in Ghana, everybody's under one umbrella. But in places like Kenya and Uganda, we have the Uganda Protestant Medical Bureau and the Uganda Catholic Medical Bureau, or in Kenya where we have the Health Department under the Conference of Catholic Bishops and the Christian Health Association of Kenya. However, all these organizations belong to what we know as HAP, and I just talked about HAP having, that HAP has up to 32, is present in up to 32 countries. So why is it important? What are the strengths of working through Christian health associations? One is the convening power and scalability. HAP and the CSHs serve as a technical convener, bringing together diverse partners across national faith-based networks to align efforts, share expertise, and accelerate solutions. What works in the Diocese of Nyahururu in Kenya, or St. Mary's Hospital in Ghana, that I've heard some of you mention, can be replicated in other places. We're also part of technical working groups. I had UNICEF ask about that at regional and global platforms. So our CHS, Peter's team will sit at technical working groups at the Ministry of Health and represent all the facilities. We at HAP will sit on forums such as the WHO Faith Initiative that Bruce from the Catholic Health Association of the US sits at. We also sit at that. We also sit at different forums at the Africa CDC, and also associate with different organizations such as the All African Conference of Churches. Another one is the scale and system-wide impact that we have. I don't have to belabor that, having talked about the 32 countries. When implemented collectively, we have gains that across the health systems. And somebody already said that silos are our enemy. The knowledge exchange and collective learning, HAP facilitates cross-country learning across its network, enabling sharing of practical experiences and expertise. We have forums for technical working groups where Lesotho, Zambia, Kenya, Uganda, everybody will sit on the same table. And so you're able to get things to everybody. Opportunity to leverage and connect systems. There's a unique opportunity to leverage existing faith-based infrastructure. And this is one of which I really pray that we can take advantage of. And we have started to do that. For example, when the Anglicans started implementing WASH, HAP has a resident capacity that is waiting for you to use. So the Anglicans used that. However, most of the time what we find is that people will start some work, have to hire new people to do the work in maybe 2 or 3 facilities, and yet the National Association has capacity to support you to do that. So if you can identify with us, it's very easy. If you go to the website, you'll find how to connect to us. Then we can help you to make life easier and get to who actually needs help more. So I talked about having a unique opportunity to leverage existing structures because we are present in communities as well. We can align efforts, mobilize resources, and translate commitments into coordinated action at scale. Importantly, like was said in the previous session by UMCO, is that we are not standalone silos. Where we exist, there's a school, there's a hospital, and there's a facility. And so getting impact is very easy. The next one is that we are also trusted providers of dignified care in many countries. Faith-based health facilities are already go-to providers for many communities, known for delivering care that is both high quality and grounded in dignity. This is deeply embedded within the communities they serve, and they are often the first point of contact for health services among the most trusted. This trust creates a strong foundation for meaningful engagement. Then proximity to power and influence. I know we have many things that we are trying to do, but on the African continent especially, faith leaders have been able to speak truth to power. I don't know about other parts of the world, but we have managed to do it at many times in many countries. I'm not going to say that it's always the case, but many times. So most of the time when we need something to happen, we're able to use the influence of our faith leaders to get it to happen by educating them, sensitizing them, and then putting them at the front lines. Some of them are on speed dial to the presidents if that needs to happen. So that is also an opportunity. Then for sustainability, faith leaders and church institutions own and govern these facilities. They shape strategy, they approve budgets, and they oversee accountability. If we're involving them and they're well sensitized, we'd ensure that WASH is not treated as a short-term project, but as an ongoing responsibility embedded in how care is delivered in those facilities. And lastly, there's an opportunity through this network to map and for systems intelligence. We are actively strengthening data and mapping systems across the sector, to provide clear evidence-based view of WASH assets, gaps, and needs. And so if you would want to make a difference and do not know where to start or who would need that support most, then you have an opportunity to work with us or the national CHs very objectively and be able to make a difference where it's most needed. And just in concluding, that faith is not just an identity, it's an operating principle for all of us here. It shapes how we care, how we uphold dignity, and we are present before funding arrives for us that do this work. We remain when it is available, and we continue to long after it's gone. The paradox is that for us, especially who are local organizations, when the money hits the table, most of the time, then people start questioning our capacity. But when there's no money, we are still on the table and we are doing what we do. So I hope that people will understand that these associations have the capacity. We've done the work, we know the local needs, and we are committed and ready to work with all partners to ensure that WASH is not just discussed, but delivered at scale with both quality and dignity. We invite you all to engage with us as collaborators. We are a ready platform nationally and regionally, and we are not in competition. We actually are there to help you to do the work that you really want to get done. Thank you.
Thank you so much, Nkatha. Once again, my name is Ruth. I support programs at HUP and specifically WASH as a lead for WASH at the HUP. So I'll dive into our approach to WASH. So at HUP, of course, we work with all our member Christian health associations across the continent, specifically Sub-Saharan Africa. So our approach to WASH, it is a stepwise approach. We start with the assessments. Key to this is that we would like to establish the functionality of the WASH in healthcare facilities. Then we are looking at the quality of care as we assess the facilities, but also we would like to see, we want to find out whether the facilities are safe for the communities. Then after that, we go into action planning. This we are doing with the respective facilities plus our members. Of course, we started our WASH work in 2018 with the Global Water 2020. Maybe I need to speak about that. So since that time, we've been having a number of multi-country support. We don't go to one country. We go to various countries in that at the end of the day, we are able to do some sort of cross-learning and then documentation and all that to make a comparison on after the WASH improvements we've made. So after action planning, of course, we establish what needs to be done within the facilities and who has to do it if the resources are not available. There are some WASH issues or IPC issues which are just low-hanging fruits which don't need any sort of resources. So as we are doing action planning, we separate them that whether this will need some sort of technical expertise, all these we can just do, or we orient or give capacity to the health workers such that they can handle them at their level. Then after establishing whether the resources are required, action planning, of course. Then we go into behavior change. This is key. In behavior change, we don't look at the facility alone. Behavior starts from the community. Of course, the community are the service beneficiaries at the facilities. If you don't engage the communities, then the facilities will never improve. The patients come from the communities. The health workers are also into the communities. So basically what we do is that we have an element of community sensitization before we bring the communities and the facilities together during our behavior change activities. Here we have activities like facility open days, where we bring the other side of the community and then the facility to interface and discuss what is going wrong, what is not working. Why is this WASH facility not working? how are you supposed to use it? Also, some of these WASH facilities, the communities can easily fix them. Like maybe to talk about cleaning of the compound. Here, you can find that even the community members can support with that because it is not technical. Then we go into data. Data is very important because it informs a lot of programming, especially as far as WASH is concerned. So what ACHAP has done, we've trained our some of the health workers and then the focal point persons within the national Christian health associations on the M-Water platform on how they should handle data, because we realized that as we do, sometimes we just want to do a benchmark of what is happening within the facilities, but the data is not available. So what we did, we trained them, and in total, we managed to train 106 of these. These are healthcare workers and then the focal point persons within the Christian health associations. So after that, we do some sort of advocacy. So this will bring me to how we work with the faith leaders. How we work with the faith leaders, of course, in every step, we make sure that they are involved. But how we do it in the different countries, first of all, our national level Christian health associations are so attached, or they work together with the national governments and other religious bodies within the countries. So what we do, when we are making entry in a country, we work with the Interreligious Council. This brings together the Catholics, the Anglican, the Muslims, and all the other denominations. When we also do, of course, when we are planning to work with the religious leaders, they don't have the skills at that time. They are designed to for the pulpit or something like that. So we make sure that we equip them with the necessary knowledge and skills. We've worked with them to co-develop sermon guides, these sermon guides which can be used within the communities and also at the facilities. But also right now we are working to ensure that at least they are part of the health center unit management committees. If we succeed with that, I think we shall also improve on governance and accountability within the facilities. So going back to how we engage them, after reaching out to the interreligious councils, they identify faith leaders who can work with us. I don't want to say that we've succeeded every time we've reached out to the councils. Sometimes they say, no, our faith leaders cannot be part of that, but others have been positive in that. So we work together to co-develop our sermon guides, and also we've managed to adapt some of them, which are already existing. These are having messages. These messages are evidence-based. They've been researched, and some of them are attached to some of the Bible verses. I mean, the verses speaking to how the community should behave and all that. So after that, of course we train them. We've trained them in risk communication and community engagement. We've also had, we had a partnership with Internews. We had some of them being trained in health journalism, not to go out and start reporting on irrelevant things. Of course, we've trained them for a purpose. So that's how we've managed to work with our faith leaders. And in other cases, like in some other countries which are in fragile settings, we've had them supporting humanitarian negotiations with non-state actors. We tried to do something and then they failed, and the communities could not access healthcare services, or they couldn't, of course, healthcare services. They were, and these are already vulnerable communities. So we've had some of our faith leaders we work with negotiate with the non-state actors, and the communities were able to access healthcare services. So, and the last step towards our work is the advocacy bit. This is very key. Of course, with our national level Christian health associations, we work to support the advocacy bit. They support mostly the national bit, but also, like Kath has already alluded to, we sit on global forums where we speak about the work. We amplify our work as the Christian Health Associations. We tell the story, and also we do the documentation. Our work is out there, and we support our members to document what they've done. So basically, that is what we do. Now, I'll move to about our commitments as HAP. HAP had our 12th biennial conference, which happened in Madagascar in February, where we had commitments from our member Christian Health Associations. So it was in form of a call to action, and it was genuinely endorsed by members who participated and other partners. And it reads that we are building on collective commitment, and HAP and members will accelerate progress by scaling WASH and IPC technical capacity across faith-based health facilities systems through proven models such as the circuit riding. And also, we were having a discussion about circuit riding, and I know one of my colleagues will come and speak more to it. Right now, we are looking at scaling the model across Africa, because I think it's a great model, and when you look at the sustainability bit, we have a lot of capacities within the CHS, like my colleague already alluded to. So it does no harm for capacity from country A to go and support WASH in another country. So that is what we are looking at. Peer learning, cross-learning, and then harmonized training approaches. After doing the assessments, you find that there are significant gaps, and some of them can be bridged by just training, like a simple training in healthcare waste management, a simple training for cleaners. HAP has also supported some, before the change in the funding landscape, we had started with Liberia, supporting our focal point persons from the different countries to undertake the fundamentals of WASH in healthcare facilities offered by the Emory University. But since we've had a shift in the funding, it has been put on hold, but hopefully when we resume, we should be able to amplify, to have enough capacities within the national level Christian health associations. So, I can continue reading the commitments.
Ruth, I think the commitments are online, so I think we'll let people, as we've been telling you, please read them online. We have a couple of the pictures from the biennial conference where people are holding up placards. We actually have those placards today. So we invite you at the lunch, and Tertullian will help us take some photos if you want to come to this area and take a photo with us, and also just to get a photo of you in this beautiful room, like the first 15 to 20 minutes of the lunch break. We invite you to do that. And then I think we'll continue on to Peter.
Okay. Thank you very much.
Yes. Yeah, many thanks, Nkata and Roach, for the overview. It provided a context for my submission. Let me re-echo 3 key points that resonate very well. The need for unity in diversity as faith-based actors, if you are to scale up WASH. And second is that to move from silos to synergies, which have been harped very well. And then, of course, to accept the fact that WASH is not optional, but it's foundational to our core mandate of promoting Christ healing ministry, especially to the unserved, underserved, and poorly served. That is very important. In Ghana, in my country, Ghana, CHAG is recognized as an agency and an implementing partner that represents all the faith-based actors in the country. And so we sit at the policy table, we influence policy, and we are very much, integrated into the design and delivery of health policy in our country. In the spirit of ecumenism, we also recognize that each denomination has its own nuanced appreciation, have different contexts. This is also recognized. And so within Ghana, the go-to for faith-based actors is CHAG. And that is what happens in our country. And we do so, once again, in a spirit of unity in diversity as well as inclusion in the policy space. So we have a shared passion for WASH. And for WASH, we recognize 3 key benefits that inspires us to always onboard WASH. One is that we have documented the evidence to the effect that compliance with WASH significantly reduces the risk of infection amongst mothers, newborns, and patients, and so many other people who come into our sector. 2, that during the COVID-19 pandemic, WASH compliance was an important tool for strengthening resilience. We saw that there were fewer infections amongst health staff working in WASH-compliant institutions. And so that helped us to ensure continuity of care for routine and essential health services as we manage COVID-19 pandemic. And lastly, we saw that WASH is the pathway of promoting trust and confidence in the faith-based health systems. So how have we approached WASH in our part of the world? We say WASH is integral into our portfolio. And so we adopt systems approach in doing WASH. We mean WASH in policies. Every policy, project, and program must have the WASH component in that, because WASH is indispensable. You can never, ever design and deliver any impactful health policy without considering the WASH component. So WASH is adopted on systems approach. CHAG also operates Safe Care Quality Improvement Program. We saw that most of the time, faith-based institutions have the perception that they operate the highest level of quality. Sorry, we recognize that it was on the level of perception. Evidence was to the contrary. So we have quality improvement program that assesses, rates, and rank our institutions on a scale of 1 to 5, 1 being the lowest and 5 being the highest. We saw that based on assessment, most of our facilities were at the lower level. And so we've integrated quality improvement program in the entire system, harmonized to ensure that quality becomes an integral part of what we do. And we are seeing clearly that there's healthy competition is leading to demand generation, and it's also leading to sense of entitlement, because patients or the public are able to see the safe care level or quality level of any institution, and by proxy, the WASH compliance level of an institution. And that is what we've done within our ambit. But clearly, what are our roles as faith-based actors? What assets do we have? And I'd like to argue from the asset-based level. We have ownership, stewardship, as well as autonomy. And that helps us to innovate, come out with innovative programs devoid of bureaucracy within the government system. And so in Ghana, in the 80s and 90s, we developed community-based health insurance scheme, and that provided proof of concept for scalability. And so Ghana now has one of the highest or the flagship social intervention health insurance programs in Africa, with 66% of the population on board. And that was that was birthed by CHAG, faith-based actors. And so that is one of the areas we have. We also have access to social spaces. And let me reinforce 4 social spaces. One is the church space. 71% of Ghanaians identify as Christians. And so the power of the pulpit, the captive audience and unquestioned authority of church leaders are always leveraged if we want to promote uptake of our programs. And WASH is also an important part of that. We also have trust. Trust has been mentioned. Trust is the biggest social capital we have. And therefore, if we are trustees of the people, we always ensure that institutions are WASH compliant, and so it will ignite trust, and trust must be worked on. We also provide stability and continuity. During COVID-19 pandemic management, we saw most of the public facilities close down, but CHAG institutions were there. Our leadership are there at any point in time. And so these assets are leveraged and harnessed to ensure uptake of WASH at all point in time. What are our commitments? Our commitments are vested in our outlook for the future. First, we need to reimagine WASH as an investment case for equity, efficiency, effectiveness, and economy in health service delivery. I think for far too long, WASH has been seen much more as a project. We need to have investment approach. What does it mean? Economic evaluation of it. And I think that will make an important case. That will mean building sustainability component in that, strengthening capacity, and ensuring that we institutionalize WASH in every program, every institution across the board and the rest. Secondly, we should expand the frontiers of partnership. Almost always, the partnership discussion has been between the provider and development partner for money. While these are very essential, we believe that probably 5 or 6 partnership components, characterized them as 5 or 6 Ps. First has to be the politicians. We need partnership with the politician. One statement from a political actor or WASH mentioned in the manifesto has a lot of investment prospects and potentials. Politicians are very important. Number 2, the policymakers, they help set the agenda for the politicians and they make things work. And then service providers, essential. They are the frontline actors. The combination of all the baseline activities, advocacy will end up at the frontline service provider level. And the 4th P is the payers, National Health Insurance Scheme. They should have ways and means of assessing the WASH component and incentivizing it. And that would be very much important. The public needs to appreciate what WASH is and the patient. Why? Because if they have sense of entitlement, they will hold our providers into accounts. That sense of accountability is vested in an entitlement, lead to demand creation and others. And then development partners. I think that partnership is indispensable if we are to pitch WASH at all levels. Together, we need committed leadership. We need champions to pitch WASH at the policy and practice level. And then finally, I think that we need to document and disseminate WASH attributions and contributions. I think that that siloed approach is not helping matters to pitch WASH at that level. Attributions and contributions are necessary if we want to attract investment case. Friends, these are some few thoughts from Ghana, and I believe that it aligns very well with us. Thanks so much.
As you can tell, we have some great resources here. If you need something, they are more than willing to talk with you, help you, form these partnerships. Peter did explain to me the difference between relationships and partnerships the other day, which is great. So yes, more partnerships. And I know we're running over a little bit, but we want to give our newest friend in this space, Dr. Ronald, a couple minutes to talk about where they're going to head with WASH.
Thank you very much, Krista, and thank you to the panelists for giving me my action plan for the future on WASH, because I believe that I'm the baby in the room in relation to WASH as a standalone or a focus project in India, because in CMAI, we have done only the integration of WASH through infection control and prevention programs, or whether it's in the community health and development projects, whether it's the school health projects, or whether the HIV mainstreaming, or it is always an integrated program, not as a standalone or a focus, particularly on WASH. I think many of you are aware, in India we have the Kayakalp initiative, which is done by the government of India on the whole WASH initiative. But unfortunately, that project or the program is only for the government public health facilities, and it does not include the Christian Medical Association of India, CMAI, or the CHAI hospitals in India. So we have a lot more to do in terms of WASH. As you have heard Sister Mary John yesterday saying that the need for WASH in India is still so high. And you can imagine, I think some of you have been there, so you will understand that as well. The government also tried to incorporate this within the Clinical Establishment Act, where they are doing, when an institution is opened, they have to go through this particular assessment. And we have the NABH, the National Accreditation Board for Hospitals. We're trying to integrate this again. It's only an integrated concept, but not as WASH. So this 2 days has been a learning opportunity for me to have a focused attention towards WASH for the organization. And for me, it's more of the future and the potential that we have as a Christian Health Association in India. Firstly, I would I really like what we heard yesterday and what we just heard, the biblical and the theological perspective to WASH. Because until or unless people understand that from where in their language and where they are, it is very difficult for them to make the behavioral change which Rod was talking about. So that has always been an experience within CMAI, that whatever we do, we have a biblical theological perspective towards that. Second thing is the involvement of the church. CMAI is the health arm of the National Council of Churches in India. And involving the church leaders at that level would make a lot of difference, because all the hospitals would belong to any of these churches within India. The third thing that my take home, again, is to make a culture, to make WASH a culture and a lifestyle within the institution, not as a standalone project or like what Peter just said, but being an integral part of the lifestyle or the culture within the institution. Then the whole goal is for us, it will be to uphold the dignity and ensuring that care is provided with compassion. In CMAI, we have this mission statement, which goes, in response to the love and command of Jesus Christ, CMAI's mission is to serve the churches in India in its ministry of healing to build a just and healthy society. And we expanded this, in CMAI, we expanded the term serve. To be scientific, to be ethical, to be relevant, to be value-based, and to be educational. So when we are integrating this within our institution, our approach will be also to serve the people. Scientifically, with systems, as has mentioned, and with ethics, being ethical in whatever we do, being relevant, and value, especially from us as Christ-like value, and to be educational in all that we do. So with this, for CMAI, it is a commitment to WASH in partnership with the Catholic Health Association of India and with all your support. Thank you very much.
Thank you all.
Thank you so much, Krista, and thank you so much to the representatives of the Christian Health Associations. I know that many folks are going to be coming and responding to your invitation to partnership during the lunch break and so on, and so really appreciate your contributions here.